Good afternoon, everybody. This is the STD clinical update with the California Prevention Training Center. Today, we'll be discussing congenital syphilis prevention for California family planning and primary care providers. I'm going to give this one more minute and then we will get started. For those of you just signing in, welcome, good afternoon. My name is Roz Platzker. I'm a clinical faculty person for the California Prevention Training Center. And this is the STD clinical update on congenital syphilis prevention for California family planning and primary care providers. We'll be getting started in just one moment. Hello, everyone. Welcome and good afternoon. We'll be getting started now. This is the STD clinical update for the California Prevention Training Center. Today, we will be going over congenital syphilis prevention for California family planning and primary care providers. It is my great honor to introduce Drs. Eric Tang and Sara Kennedy, who are going to be our presenters today. And my name is Roz Platzker. I'm a clinical faculty person for the California Prevention Training Center. So, Dr. Tang is a part of the clinical faculty at the California Prevention Training Center and is a public health medical officer for the STD Public Health Berkeley. He is double board certified in internal medicine and preventive medicine and completed his residency training at Kaiser San Francisco and University of California, San Francisco. He currently sees patients at City Clinic, the municipal STD clinic in San Francisco, and is a consultant on the STD Clinical Consultation Network. Dr. Sara Kennedy is an obstetrician and gynecologist who serves as the chief medical officer at Planned Parenthood, Northern California. As CMO, Dr. Kennedy spearheaded a California statewide initiative to expand STI screening among the 7 California Planned Parenthood affiliates in partnership with CDPH. A little bit about the California Prevention Training Center for those of you who are new to us, welcome. We are a multidisciplinary training and capacity building assistance center. You can see our logo down at the left. We're sponsored by the CDC, and we are a member of the National Network for STD Clinical Prevention Training Centers, which runs the STD Clinical Consultation Network I mentioned earlier. This is the regional map for NNPTC. So you can see California Prevention Training Center covers California, Nevada, New Mexico, Arizona, and Hawaii, and not shown Guam. And then you can see the other training centers here. So if you have any other colleagues who live in another state, you can always refer them to the NNPTC or their local prevention training center. We also run the STD Clinical Consultation Network. This is an online clinical consultation network that you can submit complex STD questions to, and a subject matter expert will reply either by phone or email per your request. Here's our financial disclosure. And here is our continuing medical education disclosure. For CME requirements, CME will be given to those who register for the course on NNPTC, and you need to stick with us for the full webinar today. So it has to be watched live and it has to be watched full. Unfortunately, we can't give CME credit to those who are viewing a recording of this, and attendance will be noted as attendees sign in. After that, you'll complete a post-course survey evaluation. That needs to be done by October 7th. And you will receive a link to that evaluation from elizabeth.olson@ucsf.edu within 24 hours after the webinar has ended. So that's the email address to keep an eye out for. Sometimes it goes to spam or junk. So if you haven't received it in 24 hours, then check those folders as well. In terms of processing, the provider is University of Nevada, Reno, and your CME notification should come in 4 to 6 weeks. That's how long the processing time takes. If you meet the CME requirements, you'll receive a notification from captc@ucsf.edu, and then that will have the link to claim your certificate. So to make sure that you see that, because that can also go to your spam or junk, you need to add captc@ucsf.edu to your safe or trusted sender. So after this, I would strongly recommend that you add captc@ucsf.edu to your trusted email addresses. And I'll bring this back up at the end, but in terms of post-webinar materials, in 2 weeks processing time, you should be able to receive a post-webinar material email notification, again, from captc@ucsf.edu. And that will include a copy of the presentation slides, as well as an access link to the recording. So for anybody who's interested in this, I'm sure it's going to be a great webinar. And if you want to pass this on, then you should be hearing in about 2 weeks, and more incentive to add that email. A couple quick housekeeping rules about Zoom. We will have speakers' microphones and videos turned off during the webinar, unless, except for the panelists. Chat will also be turned off, and the Q&A will be turned on. So if you have questions that come up, please enter them into the Q&A. The way that you do that is you click on this icon at the bottom, and then that will open the Q&A chat window, and you type your question and send. If you want to send anonymously, you can select anonymous. And you can submit questions up until the last 2 minutes of the session, of the Q&A section, excuse me. The questions from attendees will be answered either by the presenters in the chat directly, or live during the Q&A session. And administrative questions will be handled by our other collaborators who are coordinating this Zoom webinar. All right, if you have any questions, then you can reach out to Elizabeth Olson, who's our clinical program manager, and her email address is below. And with that, it is my pleasure to stop sharing my screen and pass it on to Dr. Eric Tang. Dr. Tang?
I'm on mute. Can you hear me now?
Yes, thank you.
Okay, and let me just make sure that I am presenting. You see my slides?
Yes.
Great. All right, thank you for that introduction, Dr. Platzker. So the California Department of Public Health and the California Prevention Training Center have been putting together a series of webinars focusing on congenital syphilis for different sets of providers. In December last year, we provided a webinar for prenatal care providers. In May of this year, we focused our presentation for pediatricians and neonatologists. In July, we had a webinar for jail providers, and today we will be focusing on congenital syphilis prevention for family planning and primary care providers. And I don't have any relevant financial interests disclosed for this presentation. So because we're going to be talking about congenital syphilis prevention, and really make it really relevant for family planning and primary care providers, I'm not going to focus my time on congenital syphilis management. These are kind of the three major objectives that I have for the audience, and they include going over the epidemiology of syphilis and congenital syphilis in California so that you can recognize the risk factors in your patients and screen for syphilis when appropriate. I will then discuss the expanded syphilis screening recommendations for the prevention of congenital syphilis, which are guidelines from the California Department of Public Health that were released in December of 2020 in response to the increasing congenital syphilis cases in California. And finally, I will discuss clinical manifestations and clinical management of syphilis so that you will be appropriately diagnosed and manage syphilis cases in your practice. And again, I'll be focusing on congenital syphilis prevention, but the slides which you should have received either before this webinar or after if you register for the talk. They do include slides about congenital syphilis management and other things that I may kind of quickly cover, but again, want to focus on kind of the prevention opportunities that you have in your practice, and leave time for Dr. Kennedy in the second part of this talk to discuss implementation of expanded syphilis screening in the outpatient setting. So first of all, epidemiology. So earlier this year, the CDC released their 2019 surveillance data, which stated that recordable STDs in the US again reached an all-time high for the 6th consecutive year. And this includes increasing rates of both syphilis and congenital syphilis, and will be the focus of my presentation. So in 2019, there were almost 130,000 cases of syphilis, up 74% from 2015, and 1,870 cases of congenital syphilis reported in that same year, which was up 279% from 4 years prior. CDC recently released preliminary 2020 congenital syphilis data on their website, demonstrating that the number of these cases in 2020 was again higher than the previous year. So unfortunately, these trends in syphilis and congenital syphilis are also occurring in California. As you can see in the left part of the graph, in the 1990s, syphilis rates were coming down to historic low levels, so low that we were actually on the verge of eliminating syphilis. And in fact, at the time, the CDC had launched a national campaign to eliminate syphilis in the US. However, starting about 2000, both the US and California started seeing an increase in syphilis cases among men. Most of these cases were among men who have sex with men, of whom half were also living with HIV. And this epidemic has continued to increase in MSM, and traditionally has been the population in which we associate syphilis. However, there's also been an increase in cases among females over the past few years, since about 2012, as well as increases among men who have sex with women. Nationally, there have been reports of increasing numbers of heterosexuals with syphilis who report injection, drug use, methamphetamine use, and heroin. And now there appears to be 2 separate epidemics of syphilis, one among MSM and another among heterosexual individuals, many of whom report illicit drug use. So over the last several years, California has experienced a steep increase in syphilis among females and infants. From 2012 to 2018, female syphilis cases increased 550%, and congenital syphilis cases have increased by 900%. The number of infants born to CS increased from the 6th year in a row. In 2012, there were 33 congenital syphilis cases and only 1 syphilitic stillbirth, while in 2018, there were 329 congenital syphilis cases and 19 syphilitic stillbirths. That year, California contributed to about a quarter of the total congenital syphilis cases nationally. And what makes these numbers more devastating is that CS is completely preventable and can be avoided with testing and treatment during pregnancy. So unfortunately, as with many other health outcomes, we see stark disparities in congenital syphilis by race and ethnicity. Here we see that the majority of cases were born to Latina mothers. However, the highest rate of congenital syphilis is occurring among Black infants, where the rate is over 4 times the state average, disturbing health disparities which need to be addressed. So this slide compares a map of the early syphilis incidence among females of childbearing age by county on the left, with a map of congenital syphilis incidence by county on the right. The darker the color, the higher the rate. The rates of both syphilis and syphilis rates of syphilis among females of childbearing age and congenital syphilis are highest among counties in the Central Valley, although we do see high rates in other regions as well. And in 2018, there were 10 out of 58 counties that had 10 or more cases of congenital syphilis. Many counties are seeing their congenital syphilis cases and rates increase, and some counties are experiencing their first congenital syphilis case in years, which indicates that cases continue to spread throughout the state. And we've noticed a trend in which, after seeing increasing cases of syphilis among females of childbearing age, an increase of cases of congenital syphilis soon follows. So zooming back out to statewide data, here's a list of maternal risk factors reported by mothers of congenital syphilis infants in California. So the most prevalent risk factor was limited or no prenatal care, defined as either no prenatal care or prenatal care that started in the 3rd trimester, and represents 57% of CS cases, followed by methamphetamine use by over half of the mothers. Recent incarceration in the past year represented more than a quarter of cases, with homelessness as a factor in 18% of cases. Injection drug use was also associated as a risk factor, but to a lesser degree than meth use specifically. What's important to note, however, is the context of these risk factors. Many of these women who are diagnosed with syphilis are living in a context of complex social determinants of health that may drive many of the risk factors reported. These social determinants of health include poverty, disparities in access to care, as well as stigma. These factors can result in daily living challenges that confound or interrupt prenatal care and communicable disease treatment, resulting in poor health outcomes for both the mother and baby. This slide demonstrates the link between one such social determinant of health, poverty, and congenital syphilis. On the left, the map shows congenital syphilis rates by county, while the map on the right shows the percent of population in poverty by county. Many of the counties with the highest CS rates are the same counties with the ones that also have the highest percent of the population in poverty, illustrating the importance of social determinants of health on CS rates. So enough epidemiology, let's move on to syphilis screening. So just a couple of months ago, the CDC released their new 2021 STI treatment guidelines, which updated the recommendations for syphilis screening in certain populations. So they updated information on screening asymptomatic adults at increased risk. So this includes individuals who have a history of incarceration or commercial sex work, geography considerations and race ethnicity considerations, as well as being a male younger than 29. Men who have sex with men should be screened at least annually and every 3 to 6 months if at increased risk. Transgender and gender diverse people should be screened or considered to be, you should consider screening at least annually based on reported sexual behaviors and exposure. Those who are on HIV pre-exposure prophylaxis, recommended screening for syphilis and other STIs are every 3 to 6 months, and depending on risk, and if you're an MSM on PrEP, every 3 months. People who are living with HIV should be screened for syphilis at first HIV evaluation and at least annually thereafter, depending on their risk factors and local epidemiology. Anyone diagnosed with chlamydia or gonorrhea. And then for pregnant women, there are also additional updated recommendations from the CDC. So they include that all pregnant women be screened for syphilis at the first prenatal visit, ideally during the first trimester. However, when access to prenatal care is not optimal, patients should be screened with either a serologic test at the time of pregnancy is confirmed and treated if the serologic test is reactive. Certain places, including Planned Parenthood clinics, which Dr. Kennedy will talk to you about a little more, have decided to screen all women with a positive urine pregnancy test for syphilis, HIV, gonorrhea, and chlamydia. And you'll hear about that after my presentation today. The CDC also recommends screening again at 28 weeks gestational age or as early in the 3rd trimester as possible. And again, at delivery, the patient is either at high risk for reinfection, which are listed on the screen here, or living in a community with high prevalence of syphilis. And high risk may be determined by either individual patient behavior or local syphilis epidemiology. So in addition, all women who have a stillbirth should be screened for syphilis to help determine if this could be the cause of the death. And of note, the CDC does say that a mother and neonate should not be discharged from the hospital unless the syphilis status of the mother has been determined at least one time during pregnancy, and again at delivery if they're at high risk. So I did want to point out that in the updated guidelines, they do specifically call out that certain states have recommended screening 3 times during recommended screening in addition to kind of what the CDC recommends, and clinicians should screen according to their state guidelines. So we'll talk about kind of what the guidelines are for California. So before I jump into that, in the books for about 20 plus years, the state has required that providers screen all pregnant patients at first prenatal encounter, again, ideally during the first trimester, and that the California Health and Safety Code states that every licensed physician and surgeon engaged in prenatal care of a pregnant woman or attending the woman at the time of delivery should obtain a blood specimen that shall be submitted for a standard lab test for syphilis. In addition, in December of 2020, the California Department of Public Health released expanded syphilis screening recommendations for the prevention of congenital syphilis. And these guidelines are for California medical providers specifically. We also released an accompanying Dear Colleague letter for providers summarizing the new recommendations. Given the alarming increase in rates for congenital syphilis for the 6th consecutive year in California, we recognized that there was an urgent need to expand syphilis screening to ensure detection, timely treatment, and subsequent CS prevention. So the guidelines include 6 overall recommendations for California medical providers. 3 are focused on pregnant patients, and 3 are focused on people who could become pregnant. They are evidence-based recommendations for the potential to prevent congenital syphilis. Given the alarming rise in CS due to the increasing prevalence of syphilis among people who are or could become pregnant in California, we endorsed additional syphilis screening during pregnancy in line with national recommendations, recommending additional testing during pregnancy in high prevalence areas. However, because the majority of California CS cases in 2017 and 2018 were born of pregnant people with delayed or no prenatal care, we support a more thorough, multi-pronged approach to case detection and CS prevention, which includes expanded syphilis screening for people who could become pregnant, which is where family planning and primary care providers can make a big difference. This is especially important for people identified in settings that serve populations at increased risk for syphilis, as well as patients who might have disruptions in prenatal care and communicable disease treatment due to contributing social factors. So jumping into the first recommendation, all pregnant patients should be screened for syphilis at least twice during pregnancy, once at either confirmation of pregnancy or at the first prenatal encounter, ideally during the first trimester, and again during the third trimester, ideally between 28 and 32 weeks gestation, regardless of whether such testing was performed or offered during the first 2 trimesters. So family planning and primary care providers who do not provide obstetric care can screen for syphilis upon confirmation of pregnancy prior to linking them to a prenatal care provider, especially given many mothers who end up delivering a CS baby present late or not at all to prenatal care. The second recommendation is that patients should be screened for syphilis at delivery, except those at low risk who have a documented negative screening in the 3rd trimester. These are some of the recognized risk factors for syphilis among people who are or could become pregnant, and providers should screen for syphilis delivery in these situations. And of note, the local health departments may have their own county-specific guidelines to screen all patients for syphilis at delivery, which should be followed if you are a provider that practices within their jurisdiction. The third recommendation is related to emergency department providers. I'm going to skip over this because further discussion on this recommendation and what emergency department providers can do will be covered in another webinar presentation in November of this year. The fourth recommendation focuses on jail providers. And we had a separate webinar on this topic of syphilis screening in jails that was presented in July. And anyone who's interested in learning more about that can review a recording of that webinar on the California Prevention Training Center website. The 5th and 6th recommendations really are ones that are most relevant to family planning and primary care providers. And again, you know, we realize that we need to target women before they become pregnant to prevent congenital syphilis. And this is where, you know, the role that you can play in preventing CS. So the 5th recommendation is that all sexually active people who could become pregnant should receive at least 1 lifetime screen for syphilis, with additional screening for those at increased risk. This recommendation is similar to the recommendation for at least 1 lifetime screen for HIV. In 2016 and 2017, we noted that half of CS infants were born to mothers who may have been infected prior to becoming pregnant. And expanding screening to people who could become pregnant could identify syphilis cases that might otherwise be undetected until pregnancy. When paired with timely treatment, this practice could reduce sexual transmission, potential late-stage sequelae, and vertical transmission from mother to fetus for people who could become pregnant. The epidemiology of syphilis also indicates that the peak incidence of early syphilis among females in California is between the ages of 20 to 35. Thus, this could be an ideal time for one lifetime screening, which also is a common age range in which people become pregnant. The sixth and last recommendation is to screen all sexually active people who could become pregnant for syphilis whenever screening for HIV, given risk factors for HIV overlap with risk factors for syphilis, and both can be tested using blood. Family planning settings are ideal locations to implement expanded syphilis screening recommendations due to existing focus on delivering high quality sexual health care. And it's especially important to expand syphilis testing among patients being tested for HIV, again, given the risk factors for both overlap, and there is more incident syphilis among females in California each year than HIV. So while those were the 6 major recommendations from the guidelines, here are additional strategies and best practices to consider. So using opt-out strategies, stating something like, we will screen you for syphilis along with your other blood tests, rather than explicitly asking, significantly increases uptake in screening. Offering rapid syphilis tests to screen when follow-up isn't certain. And this is typically recommended in settings like street medicine or field outreach or even emergency departments and jails, but it could be helpful in clinics to treat, as well, that treat based off preliminary rapid results, especially in rural settings where returning to a clinic for treatment could be a significant barrier. Offering syphilis screening at the time of a positive pregnancy test is also additional strategy, which Dr. Kennedy will go more into later. But you could even go even farther by screening for syphilis at all pregnancy test visits, regardless of the result. You can also perform pregnancy testing for any person who tests positive for syphilis and could become pregnant, ensuring, of course, that you're counseling people who don't desire pregnancy about contraception methods, which is also a method to prevent congenital syphilis among people at risk for syphilis. And of course, continuing to screen men per CDC and state screening guidelines. One important thing I wanted to also mention is that, if you do have a preliminary positive syphilis test, whether that's a TREP test or non-TREP test or RPR, empirically treating those patients while awaiting the confirmatory testing, especially if patient follow-up is uncertain. We're seeing many times where patients are kind of lost to follow-up, and you're really losing that opportunity if they do have a preliminary positive test to treat them if you're and not really to waiting for that confirmatory test, especially if they again are or follow-up is not certain, or if they're particularly high risk for syphilis. So enough about epidemiology and screening. I want to talk about some clinical manifestations of syphilis and the natural history of syphilis to help make sure that you are able to recognize it in your practice. So syphilis is caused by the bacterium Treponemal pallidum, or T. pallidum for short. It's a spirochete, which you can see on the slide, that is corkscrewed. It's too skinny to be visualized by direct microscopy, and an inability to culture it makes it really hard to, makes diagnosis complicated. So there are 3 general ways of transmission, 2 that are clinically relevant. So by direct contact of infectious lesions, which is usually sexually transmitted, and then vertical transmission from mother to child via the placenta. It can be transmitted through blood, such as blood transfusions, but this is now very rare as all donors are screened, and T. pallidum can't survive longer than 24 to 48 hours under current blood bank storage conditions. In terms of the incubation period, once exposed, the incubation period can be 3 to 4 weeks with a range of 10 to 90 days. So on this slide, you can see the natural history of syphilis. This infection is characterized by episodes of and stages of active disease during which patients have signs and symptoms of infection interrupted by periods of latent or asymptomatic infection. Serious complications, including neurosyphilis and congenital syphilis, where can occur at any stage of disease. So as I mentioned before, after exposure, there's an incubation period of approximately 3 to 4 weeks before a syphilis ulcer or chancre appears, which represents primary syphilis. And this initial lesion is starts off as a papule that appears at the site of exposure, and then grows and ulcerates, producing a typical chancre of primary syphilis. Classically, the ulcer of syphilis is single, painless, indurated, and has minimal exudate and can have rolled edges that are rubbery in nature. You can also see regional painless lymphadenopathy on exam as well. Importantly, since primary syphilis ulcers are often painless, they can go unrecognized, particularly if they are in the vagina or cervix, or as well as if they are in the anus or rectum. However, sometimes syphilis lesions can be a bit painful and can have multiple lesions, and thus these syphilis lesions are often confused with herpes or other diagnoses when patients have several chancres. And it's important to really keep in mind that syphilis should still remain on your differential, even if it's not presenting in the classic textbook way. It's also important to note that the chancre of primary syphilis can resolve on its own even without treatment. And it can also overlap with the next stage of infection, secondary syphilis, which I'll discuss next. So these are examples of chancres appearing after infection. So the photo on the left is the classic chancre, again, single, painless, indurated, clean base lesion with rolled rubbery edges, which can go unrecognized. However, syphilis is called the Great Masquerader, and manifestations of primary syphilis are often not textbook. So you can see the photo in the middle, and on the right, there's multiple ulcers. The middle, in a female patient, these are not uncommon presentations, particularly for people living with HIV, and these ulcers can persist during the secondary phase of syphilis, as I mentioned before. Since there are multiple lesions and potentially even these to be painful, they may be misdiagnosed as herpes, but it's really important to think of syphilis and even empirically treat patients when you see findings like this on exam. You can also transmit the infection through oral sex as well. So these are examples of that. And it's always good to do an oral exam and check for mucous membranes for chancres as well. And so, as mentioned before, the chancre of primary syphilis can resolve on its own, even without treatment. It can overlap with the next stage of infection, secondary syphilis, which is characterized by having a rash, which is the most common manifestation, often involving the palms and soles. It can also present with generalized lymphadenopathy and constitutional symptoms like a low-grade fever, malaise, sore throat, and headache. It can present with mucus patches and condyloma lata, which I will show photos of in a bit. Patchy alopecia can also occur, including around the eyebrows. Subclinical hepatitis can also occur, which is detected by lab tests revealing elevated liver enzymes, particularly elevation in alkaline phosphatase. And these symptoms of secondary syphilis also typically resolve on their own over time, even without treatment. So here are examples of the rash. It's classically diffuse, symmetric, macular, papular eruption. The copper-colored macular rash on the left is really kind of the classic rash, but you can also see red or reddish-brown papules, as seen in the other photos. Lesions are often scaly, although they may be smooth, follicular, rarely pustular. Usually they cover the trunk and the extremities, and of course the palms and soles, which give an important clue to the diagnosis of secondary syphilis. Not usually itchy rash, but syphilis can also be difficult to distinguish from pityriasis rosea. So if that is something that is in your differential, it's important to also test for syphilis. So these are examples of the rash that you can see on the palms and soles. This is an example of mucus patches in the mouth, which are highly infectious. Example of patchy alopecia. And then these are examples of condyloma lata. It's the term used for large, raised, whitish and gray lesions found in the warm, moist areas, which you can see in the perineum, the perivulvar area, or around the anus. And these are also very infectious. They can be confused for anal genital warts. So whenever you see or think about Condyloma acuminata, I also think about Condyloma lata and syphilis. And Condyloma lata generally is more flat on top compared to genital warts, which have more irregular kind of cauliflower-like appearance. So early latent syphilis is when the only evidence of disease is laboratory evidence in a history that infection likely occurred within the past 12 months. Otherwise, it's considered latent syphilis or syphilis of unknown duration, and may eventually progress to tertiary syphilis if untreated. However, tertiary syphilis is quite uncommon now. Historically, in the pre-antibiotic era, would progress in about a third of untreated infections, but again, quite rare now in the developed world, probably because of the effect of intermittent antibiotics on the development of tertiary syphilis. So again, this is the overview of the natural history of syphilis. And again, important to note that neurosyphilis can occur at any stage of syphilis. It's a common misperception that it can only occur in late syphilis. And again, even though early syphilis is traditionally considered when it's infectious in terms of transmission to sexual partners, transmission from mother to fetus can occur at any stage of syphilis. Right. So in terms of diagnosis, I mentioned before that diagnosis can be quite difficult because it can't be cultured in vitro, and direct detection methods like darkfield microscopy or PCR are not widely available. So really, we depend on serologic tests in most cases, and to make the diagnosis based on serology, you need both a treponemal and a non-treponemal test. So in terms of treponemal tests, these examples of these are in EIA or TPPA, and these are antibodies that are specific to treponemal pallidum. But they're only useful for new infections because antibodies usually stay positive for life, and there's no titer to assess for reinfection or response for treatment. And thus, it's why it's also important to have non-treponemal tests as well. So for non-treponemal tests, examples include the RPR and VDRL, and these are non-specific to syphilis. They detect antibodies to cardiolipin, which is present in the blood of patients with syphilis, but they do allow for quantitative titers to be measured to assess for reinfection and response to treatment. They generally measure disease burden with titers peaking in the secondary stage of syphilis, and then they decline in latent disease even if untreated, although as you can see in the graph, treating syphilis tends to bring titers down much faster. In some people, non-treponemal antibodies can persist for a long period of time even after adequate response to treatment, which is referred to as the serofast reaction. And in such cases, titers usually stabilize at a low level, such as a titer of less than 1 to 8, but higher serofast titers are occasionally seen, particularly among HIV positive patients. And because again the RPR and VDRL are non-specific, it is needed and required for patients to also receive the treponemal test to confirm the diagnosis of syphilis. So as I mentioned before, the RPR and VDRL can correlate with disease activity, and so is used to follow treatment response. Results should be reported quantitatively, and you can see that examples of titers on the right. If there's a twofold change, which is from 1 to 32 to 1 to 64, it's generally not considered, or that is generally considered within the margin of error of the test and is not considered significant. However, a fourfold change in titer, which is, for example, going from 1 to 16 to 1 to 4, is considered necessary to demonstrate a clinically significant difference between two non-treponemal test results obtained using the same serologic test. Sequential serologic tests in individual patients should be performed using the same test method. So sticking with the VDRL if that's what you use, or sticking with the RPR if that's what you initially used, preferably by the same laboratory. Both the VDRL and the RPR are equally valid assays, but quantitative results from the two can't be compared directly because the RPR titer are often slightly higher than the VDRL titers. So there's two different ways that you can screen for syphilis, one via the traditional screening algorithm, and another way being the reverse screening algorithm, which is being used more frequently. Treponemal tests such as the EI and CIA can be automated and does not require manual labor by laboratory staff and can decrease the cost for labs running these tests at high volume. For the traditional screening algorithm, you start with an RPR or VDRL, and if that's negative, you're done. But if positive, then the test should reflect to a treponemal test such as the TPPA. If the TPPA is positive, this indicates the patient has either past or present syphilis. The patient's clinical history, including previous treatment and titers, as well as a current RPR titer, will inform you whether it is an old treated infection, a past infection that has been inadequately treated, or a new infection. If the TPPA is negative, syphilis is unlikely as considered a biologic false positive. So, as I mentioned, some labs are now using the reverse screening algorithm where they start with the treponemal test, such as the EI or CIA. And in this algorithm, the syphilis, you start with that test, and if it's negative, you're done. If it's positive, that should reflect to a RPR to help guide patient management decisions. If that person has positive RPR, the person has past or present syphilis, similar to the traditional screening algorithm. However, if the non-treponemal test is negative, the laboratory should perform a different treponemal test, preferably one based on different antigens than the original test, to confirm the result of the initial TREP test. If a second treponemal test is positive, a history of previous adequate treatment will require no further management unless sexual history suggests likelihood of re-exposure. And in this instance, the repeat non-TREP test in 2 to 3 weeks, or 2 to 4 weeks, is recommended to evaluate for early infection, since in very early syphilis, treponemal tests may become positive before the RPR. Those without a history of treatment for syphilis should be offered treatment, and unless history results of a physical exam suggest a recent infection, previously untreated people should be treated for latent syphilis. If the second treponemal test ends up being negative, and the epi risk and clinical probability that for syphilis are low in this person, then further evaluation or treatment is not indicated. I know that was kind of a lot, but I do want to mention that we do have some guidance about the use of these treponemal immunoassays on our website that you can refer to in the link below. So in terms of how you stage syphilis, this is a flow chart that can help simplify things. So basically you ask the question if someone has signs or symptoms, if they have signs or symptoms of chancre, that's primary syphilis. If they have signs or symptoms of rash, that's secondary syphilis. And then they can also have neuro signs, ocular otic signs, which would be considered neurosyphilis, and that again could be either early or late, which depends on if you can rule in whether they were infected in the past year or not. And then if someone does not present with any signs or symptoms, if that's considered latent infection, again, can be divided into early or late. You distinguish that by determining if in the past year, whether or not they seroconverted their serologies or had a sustained 4-fold rise in their titer. If they had a sex partner with primary, secondary, or latent syphilis within the past year, if they let you know about unequivocal symptoms of primary or secondary syphilis they've had in the past year, or if the only possible exposure was in this was this past year, such as the sexual debut. So in the absence of these conditions, an asymptomatic person should be considered to have latent syphilis. Non-TREP serologic titers usually are usually higher earlier on in the course of syphilis infection. However, you can't, early latent syphilis can't be reliably diagnosed solely based off non-TREP titers, so you should really be using these criteria. So I'm going to kind of skip over this, but it is important to note that anyone that you diagnose with syphilis should have a neuro exam, and if they have any signs or symptoms, neurological signs or symptoms, that a CSF examination is needed. In terms of treatment, so this is a poll that I have, a case that we kind of just make sure that people understand, appropriately diagnosing and treating individuals. So I'll go ahead and read it, and you can answer with the poll that just popped up. So let's say you have a 24-year-old cisgender female who comes to you for a routine physical exam. When they ask you about previous STD testing, she reports having been tested for STDs while incarcerated 1.5 years ago that were all negative. You order HIV, gonorrhea, chlamydia, and syphilis testing, and her RPR is 1 to 16, and her TPP is reactive. She reports no ulcers or rash in the past year, and a physical exam is unremarkable. What treatment would you recommend? So benzodiazepine penicillin G, 2.4 million units IM in a single dose. Benzodiazepine penicillin G, 7.2 million units total, administered as 3 doses at 2.4 million units IM each at 1-week intervals. Doxycycline 100 milligrams PO BID times 14 days, or times 28 days, or azithromycin 2 grams PO times 1. So due to time, why don't we go ahead and just close the poll now. So great, 71% of people picked choice B, which is the correct answer. 21% of you chose option A. So so B is the right answer. So we'll go over that. So, for treatment of primary, secondary, early latent syphilis, the recommendation is for 1 IM dose of benzodiazepine penicillin G. For late latent syphilis, which is syphilis with infection beyond a year, requires treatment with 3 doses of benzodiazepine penicillin G at 1-week intervals, ideally 7 days apart. In terms of alternative syphilis treatment, this should really be reserved for people who have a true penicillin allergy, to get a good history from the patient to really understand if that's true, as really fewer than 1% of the population are truly allergic to penicillin, even though about 10% of people report having an allergy. But if there is a true allergy, you can use doxycycline 100 milligrams BID times 14 days for primary, secondary, and early latent syphilis, or 28 days of doxycycline for late latent or unknown duration. And doxycycline is contraindicated in pregnancy, so there really are no other options. So pregnant patients with an IgE-mediated penicillin allergy should be desensitized in the hospital and treated with penicillin. This is treatment for neurosyphilis, which is an ocular syphilis, which is different and is IV treatment. But I'm just going to kind of skip over this piece due to time. And just the reason why A was not the answer is because this person did not have any signs or symptoms, so had latent infection, and from her history, she said that she had STD testing, which may have been syphilis testing, 1.5 years ago. So that's beyond a year, which means that she would need treatment for late latent syphilis, which would be option B. And then C and D are the alternative treatments, and E is not recommended because there's evidence of macrolide resistance and treatment failure documented when using this regimen. So in terms of follow-up, for primary and secondary syphilis, we recommend doing clinical and serologic evaluation at 6 to 12 months, and for latent syphilis, getting repeat titers at 6, 12, and 24 months. In the former treatment guidelines from the CDC, they did tend to expect a 4-fold decrease at 12 months for primary and secondary syphilis, and by 24 months for latent syphilis. But there's a lot of different factors on why that might not happen. What's really important, and they emphasize in the 2021 guidelines, is that if someone has been treated and you see that signs or symptoms persist or they occur, or if there's a sustained 4-fold increase in the RPR or viral titers that are sustained for greater than 2 weeks, then they're likely you're likely are likely reinfected or experience treatment failure, and you should retreat, also reevaluate for HIV infection, and assess for neurosymptoms. Due to time, I'm going to skip over this, but it's important to get a day of treatment titer, and ensuring that you treat patients as well, or patients' partners as well, to prevent reinfection. And then, as I mentioned, this is more about congenital syphilis. It's not really the scope of the presentation today, but you can certainly look at the slides to look at kind of the manifestations of congenital syphilis. And then this is an algorithm that we have on our website about congenital syphilis management that summarizes the CDC recommendations. There is a specific talk related to this that you can view if you want more details. And then it's important to also note that you should report whenever you have a syphilis case it's required to report this to your public health department, who can help manage the case for you or find patients who are lost to follow up and get them and their partners tested and treated. Lastly, there are some resources as well from that you can view on the California Prevention Training Center website with the trainings I mentioned. Online resources also at the STD Control Branch website. Sorry, because of time again, I'm gonna just the take-home points is that really there are an increase in syphilis cases in females and infants in California, that there's opportunities really for family planning and primary care providers to prevent congenital syphilis, and to really try to report these cases to your local health department within 1 business day, and so that they can help you. And if you have any further questions, you can feel free to reach out to me. And also we have a resource, the STD Clinical Consultation Network, which if there's any kind of complex questions you have about syphilis treatment or any STIs, you can also use that as a resource as well. So I'll stop there and hand it over to Dr. Kennedy.
Thank you so much, Dr. Tang. So I'm really happy to be here to talk about our affiliates' experiences with expanded STI screening, and particularly expanded syphilis screening for our patient population. I have no disclosures that are relevant for this presentation. Just to give you all some context about the Planned Parenthood setting, and specifically Planned Parenthood Northern California, we have 17 full-service health centers that spread over 20 counties. So we serve quite a geographically diverse patient population within urban San Francisco, suburban Bay Area, and then the rural north. And we see approximately 172,000 visits per year for clinical reasons. Our patients are really diverse. They're diverse racially, ethnically, and geographically. So largely, we see a younger patient population, though not exclusively. So 53% are in the 20 to 29-year-old age group. 84% of patients have a vagina. We see largely a lower socioeconomic status patient population, with 88% living at or below the 200% of federal poverty level. And then importantly, we provide confirmation of pregnancy to tens of thousands of patients per year. And this is important because nationally, we know that approximately 60% of patients with a confirmed intrauterine pregnancy end up having a desired pregnancy and will continue that pregnancy. And so this became very relevant for us. In 2017 and 2018, we recognized that there was a syphilis hotspot and a syphilis crisis happening in Shasta County in our Redding, or near our Redding Health Center. And we at that time set a series of goals for expanded STI screening that encompassed expanded syphilis screening. We worked collaboratively with the other 6 California Planned Parenthood affiliates to establish evidence-based goals that were aspirational. They had not yet been, especially for the syphilis screening, we were on the cusp of recognizing this epidemic of syphilis, and recognizing that across all 7 California affiliates, and that those 7 California affiliates saw more than 1 million confirmation of pregnancy visits. And so this was a real opportunity to make an impact in the area of congenital syphilis prevention by trying to capture all those patients right at the diagnosis of their pregnancy. And so working with the other 6 California affiliates, as well as the California Department of Public Health, we came up with a series of goals that we would work towards. Every affiliate, we viewed this as a menu of options, and that different affiliates across the state of California may choose to emphasize different goals for different reasons. At Planned Parenthood Northern California, we chose these first 2 highlighted goals. So the first goal, we kind of coined the core 4 screening. And this meant that at the initial diagnosis of pregnancy, that we would recommend gonorrhea, chlamydia, syphilis, and HIV, known as the core 4, to patients. And so that was whether patients came in for a urine pregnancy test or whether they presented for that initial ultrasound, which confirmed their pregnancy. The second goal that we chose to emphasize or to focus on in 2018 was what we called linking HIV and syphilis. So in addition to screening all individuals for HIV and syphilis at least once in their lifetime, we really made it a point to emphasize how important it was to link those 2 tests because many of the risk factors are shared. So while we were doing an excellent job in HIV screening, we were doing a remarkably poor job in syphilis screening back in 2017. And so we really linked these in our clinicians and our medical assistants' minds. So if you were screened for HIV, you should be screened for syphilis and vice versa. And then you can see the other goals that we also were working towards, but we were really trying to emphasize these first 2 goals initially. There we go. So this is just gives you an overview with a couple of data points of our timeline. So importantly, back in 2014, we had actually been approached by the Contra Costa County Department of Public Health requesting our assistance in treating syphilis, that there were limited resources by the DPH in Contra Costa County, and they really needed public health organizations like ours to step up and to also offer treatment. So back in 2014, we began treating for syphilis. And so that was already a well-established process as we kind of headed into this 2018 pilot. So again, in Shasta County in 2018, Department of Public Health, as well as our Redding Health Center, we're really seeing an acute spike in cases, not only MSM patients, but also cisgender women who were being diagnosed with syphilis. We then decided to launch a pilot, and shout out to both the Redding and the San Francisco Health Centers, where they were our initial pilot sites for our core 4 screening, remembering that at the confirmation of pregnancy visit, those patients would be recommended to have gonorrhea, chlamydia, HIV, and syphilis that same day. And then in 2019, we added on that linking of HIV and syphilis screening as well as core 4, and we launched that affiliate-wide over all 17 health centers. So interestingly, and a little bit sadly, in February 2020, you'll notice that we did a little data check and saw that our initiatives were working, that we actually had a 400% increase in syphilis screening between 2017 and 2019, and that 77% of patients who had been screened for HIV were also being screened for syphilis. Unfortunately, that is when COVID hit, as we all know. And so this took a little bit, we paused on some of our expanded STI screening initiatives in March, and then we relaunched core 4 screening in August of 2020. And then of note, we've now actually moved forward or are about to move forward with adding hepatitis C to that core 4. So it will now be called the core 4C screening, given CDC's recommendations that all pregnant patients should be screened. And I would also say that another reason that we felt strongly about the core 4 screening, if you remember Dr. Tang's slide, that the #1 risk factor for congenital syphilis is delayed or inadequate prenatal care. This is something that we know that our patients experience regularly, and particularly in the rural north, where prenatal care providers are few and far between, especially those who serve the poor. And so what we're seeing with our patients is we may diagnose them with pregnancy, they may have a desired pregnancy, and we would refer them for prenatal care, and it may be 12, 14, 16 weeks until they could actually establish prenatal care. So that was really the kind of movement behind trying to make sure that we do this important screening right at the diagnosis of pregnancy. So what were some obstacles that we found early in our pilots in Reading and San Francisco? The first thing was just like, syphilis, really? Like, I've never seen that as a clinician, or I didn't think that was a thing anymore. And so it really was important that we started from kind of ground zero, making sure that we talked with all medical assistants as well as licensed staff about what syphilis looks like, about the rising rates of both syphilis and congenital syphilis, and really making sure that people understand that the reason that we're emphasizing syphilis screening is because these rates are going up across many populations, and that congenital syphilis is an entirely preventable disease that we can and should stop. The second major obstacle that we found is that when we did, after a couple of months of the pilot, we of course were analyzing our data as we went through, and we noticed that there were many unresulted RPRs from Quest. And so at PP NorCal, we have made it a point that we try to do all of our blood draws in-house when possible. And yet we were seeing so many unresulted RPRs that were actually supposed to have been drawn at Quest. And so when we did a little bit of digging into the pilot sites, what we found was that the phlebotomy skills of the medical assistant staff they weren't totally confident in their phlebotomy skills. And so it was an easier thing to say, hey, you know what, instead of doing a blood draw here, let's just refer you out for that blood draw at Quest. But then, of course, for our patients to try to get to yet another facility that might not be anywhere near their house, or where they may need to take time off of work, or they don't have childcare, they ultimately largely never went to Quest for that blood draw. So we had to do a couple of interventions. We had to, of course, provide phlebotomy skills support to our frontline staff. And then we had to do just little things of making the phlebotomy supplies easily accessible so that convenience was part of that patient visit, and making sure that staff understood that whenever they referred a patient to Quest for a blood draw, there was a very high chance that that patient was not actually ever going to get that blood draw through Quest, because it was just too difficult for them to go to. And so it was really important that we did this in-house. And then another obstacle is we were told that patients were declining expanded screening. And of course, I'm using air quotes when I say declining, because the question for the staff was, well, why? And for patients, why are you declining this? What we found early on was that our language around counseling for syphilis screening in particular needed to move from an opt-in place to an opt-out. So instead of saying to a patient, hey, if you want to be screened for gonorrhea, chlamydia, syphilis, and HIV, you can hang out here. It's probably going to take another 20 minutes of your visit. Let me know if you want to be screened. Two, based on what you shared with me today during your history taking, we recommend testing for gonorrhea, chlamydia, syphilis, and HIV. Please let me know if you don't want to be screened. And then if the patient expressed further hesitance around being screening, that is when then we would take the time to do kind of more patient education around why that screening was important for them as an individual, and also for the rising rates of syphilis in California. So we provided that little script with training to all health center staff. We immediately saw a boost in our numbers of patients who were then opting to have syphilis screening. And then we really kind of looked at trying to maximize or minimize all unnecessary venipunctures, maximizing times when we normally would be already kind of doing a venipuncture, such as if we were placing an IV for a procedure, educating staff that that's actually a time that you could do an RPR and a hepatitis C, and thus kind of decreasing the amount of venipuncture needed for patients. Another major cost, and this continues to be a very real issue, is about insurance coverage and cost of screening. So this just gives you, we established, again, during the pilots, we realized we needed a job aid that really helped our frontline staff be able to accurately tell patients if their insurance would cover syphilis screening and then syphilis treatment as well. And then to have kind of readily available sliding scale fees for syphilis screening and for core 4 screening. And you can see all of that information here. And then we also recognized that part of the way that we took sexual health history and our documentation was not supportive of this expanded STI screening and syphilis screening initiative. So as a result of the pilots, it really helped to inform a total revamp in the way that we do sexual health history taking. And so we optimize the sexual health histories. We offer training to all of our staff. The goal was to conduct a more efficient but equally effective sexual health history, to destigmatize it, and to make it patient-friendly, gender-neutral, and non-judgmental at all times. And so we changed the way we asked certain questions, and sometimes it was just reordering questions to establish people's risk factors and whether they should be screened or not. I'm asked frequently, like, what helps? So we really were highly successful at increasing our syphilis screening rates across all populations. And so, of course, incentives, staff love incentives. So pizza and bagel parties were hugely popular. Obviously, in the era of COVID, that becomes a little more challenging. But what we really did is we set metrics for our health centers, we set these goals for our health centers. Two common goals that we used were a goal of 80% of patients screened for HIV will also be screened for syphilis, and a month-over-month 10% increase in urine pregnancy test positive patients screened the same day for core 4. And so those were goals that the health centers had. If they met that goal, they got a pizza party at the end of the month, and it was highly motivating. And then the real-time reports were also really important. So we drilled down at both an individual staff level and a health center level to identify any individuals who were struggling. Potentially there might be one medical assistant who was really not confident in their phlebotomy skills, and we saw all of their patients were being referred to Quest, for instance, and we knew we needed to support that person in phlebotomy. As well as centers. Health centers might have workflow challenges that we could then drill down on with those real-time reports. So we did make some workflow adjustments for all of you out there. These things sound really small, but for those of you who run health centers, you know how important these tiny little tweaks and workflows can be in clinical initiatives. So one of the important things we realized is that we needed a method whereby the entire patient care team would recognize or be able to identify when a patient should be screened for syphilis. Also, the labels became a real barrier. We needed a centralized location. We wanted people to be able to go into a room with all the supplies they needed, including those labels for the blood tubes. And so just identifying a centralized location where people could print and pick up those labels was important. And then finally, streamlining the lab order process. So all these little things that we got into really made a difference in increasing our syphilis screening rates. I just want to give a really big, sincere thank you to the other 6 California Planned Parenthood affiliates. We've been working as a team to combat congenital syphilis. And then the California Department of Public Health, including Dr. Tang, have been so supportive and accessible, and it has been really a joy working with them. So thank you for the opportunity to present, and I'm happy to take any questions.
Hi, sorry for the dead air for a minute. It was having a little trouble with my camera. So thank you both so much. Let me just post one screen really quick, and then I would love to talk about a couple questions that we have. We've got a couple minutes. So I'm just going to share this screen as a quick reminder. And let's see, here we go. Okay, so some quick post-webinar materials, approximately 2 weeks until everything is processed. Please add capdc@ucsf.edu to your safe and trusted senders, and the email notification will be sent out to the email address that you used to register. So whatever you use to register for this is where you will receive your webinar recording and the slide handout, okay? All right, so moving on to questions. We had a couple good ones come in. The first one is a clinical question. I wanna punt this one to Dr. Tang. If a pregnant person is treated for syphilis during the first trimester of gestation, do we need to test at 28 weeks and at delivery? So what do you think?
That's a really great question. You know, I think the 2015 STD treatment guidelines to the CDC were, I think, a little bit confusing because it even suggested that we should be screening every month after someone's treated for syphilis, but really that we kind of favored really not screening until kind of no sooner than 8 weeks after treatment, unless there's concern for treatment failure, reinfection. But someone who's treated in the first trimester of pregnancy, you don't necessarily follow the same screening recommendations. They kind of can be screened again at 8 weeks is kind of the minimum time, but you would certainly want to screen at delivery. If at 28 weeks, it's still within that 8-week period, then you don't necessarily need to screen. But again, screen again at delivery is kind of the main piece that is important, and that you may follow up with titers kind of 8 weeks after they're treated. But what we know is that titers typically don't drop that soon after, and frequently testing someone who's already been treated, it can just be kind of confusing because titers do tend to fluctuate a little bit, and people get concerned if there's a twofold increase. So just to clarify, I guess, certainly to screen at delivery, and then you can screen again after 8 weeks after you treat that person. But if you want to continue following up on their titers, or if there's a concern for reinfection or treatment failure.
Great. Yep. Okay. Next question is a question that looks like it would be a good one for Dr. Kennedy. So Dr. Kennedy, I'm not sure how many Planned Parenthoods use the reverse screening algorithm, if any. This one has to do with that and billing. Is that something that Planned Parenthoods use?
We don't generally use the reverse screening algorithm, no. So we follow Federation protocols. So no, we do not.
Okay, well, I don't know if you would know this, so then this will go out to both of you. If Medi-Cal covers reverse screening algorithm, according to the current Medi-Cal lab services grid, it seems like they only cover a qualitative RPR, and then it reflexes to quantitative and non-TREP. So Dr. Kennedy, I thought with your clinical experience, you might know this, but Dr. Tang might know as well, or maybe neither of you do, in which case we will look it up.
I know for sure that Family Pack does not currently cover for the reverse screening algorithm. I know that for sure, and that's something that we're talking to them to see if they can potentially cover in the future. I believe Medi-Cal does cover it, but if you're that's something that we can definitely look into and ask. And I see the person who asked that question, so feel free to send me an email and with the Medi-Cal laboratory services grid, and then we can ask our partners over at the Department of Healthcare Services. Okay, excellent. Thank you both. Okay, we have 2 more minutes, and so I want to find a quickie. Let's see. So this one, I think I can send this out to. Sorry, I see Dr. Kennedy. I see you typing an answer to someone. I'm like, oh no, I won't ask that one. So there's a few questions for people in the audience who are getting written answers. Some might have gotten some from me, and some may be getting some from Dr. Kennedy. Now we're trying to sort of triage as much as we can in the last minute. Let's see. Oh, this one's a good one for Dr. Tang. What are the acceptable lesions or sites to swab for Darkfield? So let's end on a primary Schenker note. Yeah, so you can certainly do Darkfield testing. Secondary lesions like congenital lata, if you see that as well. The one thing that you do not want to do a Darkfield test on is any kind of oral specimens, because there are commensal spirochete infections that are non-pathologic that can be found in the mouth, and those could be misdiagnosed as T. pallidum in the Darkfield. So I would say any kind of lesion that is infectious, like I mentioned, the Schenker or tunnel levulata that you could test, but nothing that from an oral specimen.
Okay, excellent. Dr. Kennedy, anything to add?
No, I'm just very happy to be here, and very happy also if people have questions about kind of real life experience offline, you can engage with me anytime and we can try to share best practices that we've learned.
All right, and with that, it is 1:15, and so thank you, Dr. Kennedy and Dr. Tang, both. It's been a pleasure hearing your presentation, and also always a pleasure working with you. And so thank you also everybody who stuck with us for the full presentation, and I hope you all have a nice rest of your day. Bye.